Yeah, there you go.
Okay, so thanks, Jens. Thanks for the introduction. It's been a long time since I've seen you and Rod, and at some time I'd want to definitely come out there. And so thanks for the invite. So this talk, obviously, is a short talk, 30-minute talk or less. So what I thought about was just talking something about the spine, but more of a concept talk, and I'll tell you why. So first of all, just as a background, that's most of these buildings you see here are Houston Methodist, and as you can see, it's a huge. When I applied for the job here, they said to me, the TMC is like the Egyptian pyramids. It'll never be built again. And it's probably true. It's a massive city. It's a city. It's the TMC, the Texas Medical Center, is like a city in itself. But this is all, all these buildings, mainly a lot of them Methodists, what you can see here now. But obviously we have Baylor, we have St. Luke's around, we have MD Anderson. So it's a great place to work. And it's been a really exciting 8 years for me, and I've just signed another 5, and so it's been a really good thing. So what I'm going to talk to do today is, again, it's a short talk. It's just about the concept of why I argue for the surgical treatment of a type 1 spinal cord fistula. And you saw the last guy's presentation. It's a very simple operation, okay? I'm going to just quickly go through this, and obviously for the residents and fellows, when you look at what we call the Conus Medullaris Syndrome, what they present with, as you described before, low extremity weakness, low back pain, sensory level, constipation, and urine retention and impotence. So that's obviously is going to affect the conus, which can be from multiple different sources, but what we're going to focus on today is the vascular causes. So what vascular causes are associated with the syndrome, and it's largely 3 things: a spinal dural fistula, which is by far the most common, a spinal epidural AVM, the type A, and also, as we described, as I said before, this perimedullary AVM at type 4. And those are the symptoms you always got to worry about. So if you get a patient with those symptoms and everything else is negative, always think vascular, okay? So as the guy said earlier, what is a type 1 or dural type spinal fistula? It's an underdiagnosed entity, and I see it all the time. I see people for having symptoms for 3 to 4 years before they get diagnosed. Men are affected far more common than women. The mean age diagnosis is 60. Younger than 38 is very rare. And up to now, no patient younger than 20 years of age has been reported, and 80% of the fistulas are located between the T6 and L2. But I think from this slide, the biggest take-home message is that if it doesn't make sense and people have weakness in the conus or thoracic spine, always think vascular. And I think, we as neurosurgeons and orthopedic guys that do spine, we think about this. But I think you think of the average neurologist, it's such a rare diagnosis that they think of MS and infections, but they never, and not never, but often do not think of a vascular lesion. That's important for us to educate people. And when you see those secondary consults, think of a fistula, even if the MRI is not completely conclusive. So this is example what in an ideal situation, what it looks like. And you can see on the left panel, there's a thoracic cord, and you see these little flow voids on that side. And the other thing that's important to figure out with a type 1 fistula is the edema in the cord. And that edema will tell you there's something going on. So obviously, if you look at the right panel, a person that's not thinking vascular will see that expansive cord, will say this is probably going to be transverse myelitis. They're going to miss it. The patient will be put onto steroids, and he doesn't get better. And 3 or 4 years later, he becomes paraplegic and doesn't get better. But always think of fistulas when you see these type of pictures. But that's the classical one. On the left is the classical one. And on the right panel is, that's what you can find with just a suggestion of some vascular flow voids. So the problem, I think the big thing to understand when you treat spinal dural fistulas, all this is a shunt. It's a shunt at the dural margin of the nerve root draining to the coronary venous plexus, and that's what it is. That's the basic problem. And this is a nice illustration, and I'm not sure if you can see my pointer, but obviously you can see the order, and there you've got your radicular arteries, and there's your fistula at your dural edge, and that results in venous reflux into this coronary plexus, which results in venous stasis. So most of these are dural, as we said before, but I think you must understand as a spine person that is the problem. That is not the problem. That's the problem. And I think many people think, well, just think about the vein, don't worry about the fistula, but you have to understand that is where the problem is. So that's just kidding. So obviously, you always think, well, why, does a spinal cord fistula result in paralysis and weakness? And the bottom line, as I discussed earlier in discussion, venous congestion. So what venous congestion does, it leads to chronic hypoxia and a progressive myelopathy. And the Germans, as typical Jens will understand, have done the measurements, and they've showed that the pressures can be up to 75% of a systemic arterial pressure. So you can imagine, when you have this, how much stress the spinal cord is. The vein as a role, the vein is taking away the metabolites and all that away from the spinal cord or the brain. And if they cannot get rid of it, this is going to lead to chronic injury over time. So that's the underlying mechanism. So you must understand, when you talk type 1 dural fistula, it's a simple fistula. It's a simple connection between the artery in the vein, in the dura, that leads to chronic hypoxia from chronic venous stasis. So obviously, the worst scenario is this Foy-Alone syndrome, where they get a subacute necrotizing myelopathy. It was described already in 1926, and that's what you'll find on the left panel, where you can see these dilated veins, and that's the extreme of what we have with most spinal dural fistulas. That's when the necrosis happens in the spinal cord and the whole spinal cord infarcts, and these patients do not get better. But as we all know, that most of the patients present with just progressive myelopathy and much, much milder symptoms than this, but this could be the extreme, and if you don't treat them, that's what happens. And that's just the case reports. It's a rapid progressive myelopathy. That's when you discussed the other case earlier. I thought, well, that's what you're going to talk about, but that's what it is. It's irreversible, poor prognosis, and I've seen one. I saw a patient, actually, Jens, one of my last few patients I saw in Seattle was exactly that. It was actually a Russian pilot, which is ironic today. And he was not a pilot, he was a paratrooper, and in the Russian army, and he had a big fall, and he wasn't paralyzed after the fall, and about 10 years later, he became weaker and weaker and weaker and was never diagnosed. And when I saw him in Seattle, he had a clear fistula. He was complete paraplegic. We operated. He never got better. So that is exactly the stream. And that's what will happen with the natural history of these diseases. So just to recap, what is the diagnosis? I think the clinical history examination is important. And that the important part of that is people present with a progressive myelopathy. It's not a static. If someone presents with an acute loss of spinal cord, you think about vascular, but it's not usually a fistula. It's usually either infarction or transverse myelitis. But this is a progressive lesion that starts with some back pain and it gets worse. I think most of us now understand that a really good way to diagnose this is MRI, but still, as I said, I showed you the other image, is that MRI is not the gold standard. It's something that you can use as a data point, but not the complete picture. I still think if you suspect it, go ahead and do the angiography. People were always scared about spinal angiography before, and the risks were high, but these days it's so sophisticated, we do so many of them, that the risk of a spinal angiography is essentially 1 in 10,000. So I think if you have a suspicion, it's your duty as a surgeon to get that angio, even if the MRI is only equivocal, to make sure the patient doesn't have a spinal fistula. And then obviously in the olden days, where Jens and myself were in Seattle, we still got the CT myelogram, and that's how you also can make a somewhat of a diagnosis. But this is not a diagnosis you're going to make without an angiogram, but you've got to think about it when you see that constellation of symptoms and say, well, what can be causing this patient's problems? And then if you cannot make a diagnosis, I still get angiograms in those cases. So we showed you before, that's what it looks like on the MRI scan, the dilated veins, the edema in the cord, and that's the classical diagnosis. Most radiologists will see that in big centers and say, that's a dural fistula, that patient needs to get a spinal angio. And that's an example of one of the cases, 67-year-old male, weakness, onset constipation, urine retention, showing that, and that's what it does. So that patient went to angiogram, and I think getting back to what I said earlier in my talk, this is what is type 1 spinal dural fistula is. Okay, that is the catheter, and that's one of the catheters we use for the spine. That's the radicular artery. And I will talk a little later there, if you can see my pointer, that's the fistula, and that is the vein, okay? So when you look at that picture compared to the angiogram you showed me earlier, they don't look the same, but that is what a type 1 dural fistula is. And unless you see that, think of something else. So that just highlights it again, and I think if you're going to do these cases, it's a very simple case. You have to understand the pathology. And when you understand the pathology, as I said earlier, you've got to understand where is the fistula, where is the actual problem. And I'll talk about that. And part of the reason I'm talking about surgery versus endovascular is you've got to understand exactly where the fistula is. So there's the radicular artery. I'm not sure if you can see my pointer. And there's the branch that's feeding the fistula. There is your fistula. So that's the dural nerve root fistula there. and then that drains up into the vein, and that's the vein. So the pathology, and Jens and Rod, if you even ask many neurosurgeons that don't really see a lot of these cases, they'll think that's the pathology of that vein. So they'll go inside and ligate the vein surgically at this area. And I've seen it before. You as you get older, you've seen everything before, and I've seen it. But that's not the problem. The problem is here, and that's what you've got to address. If you don't address that, you're not going to cure the problem. And that's with the feeding artery, I said before. That's the AV shunt. That's the draining vein. And what we get these days, and that's just been a new addition, is to get a Dyna CT. I'm sure you guys get them there. And that truly gives you a very, very good idea of the pathology. And there you can see there's the fistula, there's the draining vein. And you can also, when you understand the disease process, there's more than type 1 dural fistulas. Without a Dyna CT, I find it really hard to actually make the diagnosis of excluding some of the other fistulas. We know this is the most common, but often we say, well, it is that. But actually, when you get a Dyna CT, you can see a big vein up here. That'll be a different disease. And I'm still not sure that case, you had a nice vein, but it may still be a combination of the case you show. But I think getting a Dyna CT in the angio is also extremely important for you to understand the disease process, understand where the fistula is. And you've got to understand that's the problem, that's not the problem. That's a secondary problem. That's the primary problem, and that's what you've got to go and fix. And that just shows you again, on the Dyna CT, and that's the same case showing you. The other way you can do this is with a myelogram. I think Jens and myself, when the days where that we diagnose that, and as I say, the classical thing is like a plate of spaghetti. And what you find your corticoquina, you find expansion, but you find these little spaghetti roots, and that's the way you do it. These days, we'll diagnose with MRI and angio, but very occasionally we'll still see a patient get referred in after you had a myelogram for unexplained problems, and you'll see that, and a good radiologist, an older radiologist, will obviously make the diagnosis. So the whole question of the talk, and I said it's a short talk of 30 minutes, but I want to teach you guys, and I want you to understand, what your goal is and why I think surgery should be the first option. And I'm actually in the minority. If you go to most endovascular or vascular meetings, people still say endovascular, and I'll show you why. I think endovascular is important, but I wouldn't want it for myself in this disease. If I have an aneurysm, a basilar aneurysm, I want mine coiled. If I have an ACOM aneurysm, I want mine coiled. But if I have a type 1 dural fistula, I'll show you why I want this treated. So the goal of the treatment of a spinal dural fistula is essentially halting the progression of the disease, okay? And the only way to do that is to disconnect the fistula from the coronal venous plexus and therefore decrease the vascular pressure of the fistula and the venous congestion of the cord. That's your goal. I think Jens and myself know we were in Seattle, and we always talk about what is the goal of the operation. What's your goal of the operation? And that's what I teach my residents. Always understand what's your goal. And this is your goal in the spinal dural fistula. You have to get rid of the fistula. And I'll show you some cases where that doesn't really happen or excessively happens. So as the guy said earlier, what are the treatment options? Unfortunately for me, I see that embolization of the fistula is now the first-line therapy, and microsurgical ligation is becoming a second-line therapy unless you have a lot of experience as a surgeon. As I discussed before, observation is not an option. If you look at the natural history data, it's poor, and most people will become progressive. And unfortunately, once it progresses to a certain level, patients cannot get better. So you've really got to think about this. But I think the big thing about the talk today, I'm going to show you why I think embolization should be secondary and microsurgical should be first if you're the patient. I can tell you that now for a second. So getting back to obviously the two different options, historically embolization materials utilized with PBA, and I think Jens in our days, Joe Eskridge used to do that. I did it with him when I did my fellowship with him. Embospheres I never used, but people used them. They used silk sutures and dura, and this is the way to go and embolizers, but no longer is that utilized. And now the two agents we use for embolization is glue, and then the onyx, which has obviously been a revolutionary in regard to fistulas in the brain, and people are using them more and more for the spinal fistulas as well. But those are the options you have now. So the big thing, and this is the issue about the talk, and the talk's not going to be rocket science, but it's going to be philosophical. And this is the philosophy of a very well-trained endovascular radiologist that always realizes this. Most guys aren't well-trained. If you see a lot of there's too many fellowships out there now. People don't understand this disease, even though it's a simple disease. And this is one of the really important concepts you have to understand if you're treating this endovascular. If you do not see the embolization material in the vein, the fistula is still open. But that's an important concept. So even those radiologists that do this all the time, and neurosurgeons, that's an important thing to do. And some people don't realize that, okay? And for most good people that are not dual trained or radiologists or neurologists, if embolization is not complete, send the patient to surgery. Okay, but that's an important concept. So that's if you ask your average guy that doesn't think like I do, you've got to embolize into the vein. Okay, that's what they say. That is this gold standard. You go to any endovascular meeting, they say that, and they're correct, but they're wrong in being correct. So getting back to that case before, that's the fistula, as we discussed before. Feeder, AVM shunt, draining vein, and this is what an embolization with onyx looks like. And this is a case where it is worked really well. And this is a case where the patient will get better, and there's no chance that you've inadvertently hurt the patient. So why I'm saying that is that's the catheter. You saw the fistula before, and your cast, remember I told you before, your disease process is the fistula. It's not the draining vein, and your onyx cast is actually at the nerve root zone, and it goes on the epidural space, but it doesn't go up all the vein, okay? So this situation, if you can replicate this every time you do an endovascular embolization of the spine, then I would say to you, endovascular is the way to go. That's what you should do, because you can, without opening the guy's back, even though it's a minor operation, if you can control your glue and onyx to this extent, you should do endovascular, okay? Unfortunately, the world's not perfect. I'm not perfect. No one's perfect, and that doesn't always happen. So this is another case of another case. Same thing. There's the fistula, and there's the draining vein, okay? So what you want to do in an ideal world with embolization is to go inside and just treat that and have glue in the vein. They are completely correct. You have to see glue in the vein. I'm going to go back for a second. There is. Remember, the fistula is there and the vein is there. So this is a correct embolization, and this is perfect. So you have to see that. And if you don't see this, what I see sometimes, Jens, patients will embolize that part. The fistula is still filling. You get a spinal angiogram, and the patient is not getting better. And what they've done is they've taken away the highway to the disease process, but they haven't taken the disease process away. So what happens is there's still reflux there now through little collaterals, and the patient still has venous hypertension. You get the MRI scan, and the MRI scan shows that the patient's still got a spinal cord edema. And that, to me, is the worst thing you can do for patients. And unfortunately, I see that all the time. People under-embolize sometimes, and then they get this situation where they just treat the feeding vessel, but there's more than one feeders normally to that fistula, and they still have venous hypertension. They say, well, I've done the job. I'm a great radiologist or a great neurologist or a great neurosurgeon. I don't see the fistula. And it's true, they don't see the fistula, but they also haven't cured it. So Jens and Rens, I hope I'm making it clear. What I'm trying to say is that you have to see embolic material in the vein, not just occluding the fistula angiogram without getting to the vein. And I think, as that slide said before, many people, if you ask, I'm sure 1 in 10 endovascular neurosurgeons, they'd be happy with just treating the radicular artery and not worrying about getting this picture, okay? So that's the one thing. So many people with endovascular therapy can under-embolize the AVM. This is a different situation. So now you go inside and give onyx, and what do you see? Yeah, this is all cast, okay? That's the fistula. There is casts all along this vein, okay? So what you've done in this situation, and unfortunately this happens more than it doesn't happen, and what you've got, so you get your angiogram, that fistula is completely gone. You've treated the fistula itself, but also you've got contrast, you've got embolic material in the vein, but what you've done is that you've occluded the vein all along that spine, and that, thoracic spine, that could be pretty difficult for the patient. In regard to this microsurgical ligation, as you said earlier, okay, there it is. There's a spinal fistula. You go inside, you identify it. I don't put clips inside there because that's going to take away space. All you need to do is to open it up, coagulate it, and you're done. These operations can take you 45 minutes, okay? But the concept here, and I've discussed before, is this is precise. I know completely. I go inside there. There's the fistula. I ligate that fistula at that site. I don't ligate all the veins, higher up in the cord or lower down the cord. This is a precise procedure. I know exactly the fistula is gone. I've treated the fistula, but also I haven't resulted in excess venous reflux in the disease process. So obviously, this is a concept talk, and people will say, well, Gavin, you're wrong. Endovascular is perfect. We can under-embolize, we can over-embolize, etc. It's going to still be fine. But then look at the results. I always say to people, look at the results. I think, number one, I agree with people. The prognosis is very dependent on the duration of symptoms before treatment and the pre-treatment disability. Much like that Russian paratrooper that I saw in Seattle, actually one of the last patients I saw, he never got better. And I followed up with that, when I was at Duke, and he never got better. He had, necrosis of the cord and from long-standing hypertension. But also in the patients that actually we do treat earlier, only 2/3 of all patients have progression of their motor symptoms, 1/3 show improvement of their sensory disturbances, and impotence and the sphincter disturbances are seldom reversible. So in 2021, February, whatever, the 2nd or 3rd, we are still only making 2/3 of our patients are getting better. So Jens, if I ask you that I'm going to say to you that you're going to do your spine operations and this is your results, you wouldn't be happy with that. But unfortunately, people are completely happy with this. And this is the data. This is the data from many, many series, 2/3. Obviously, there's going to be some of these patients going to belong to this group where they aren't going to get better because it's delayed. But still, we're not doing our job. Our jobs as neurosurgeons, regardless of the disease process, is to try and get perfection. You have to try and get 100% of these patients better. If not 100%, 99%. And we are only at 2/3. Okay, we're not doing a good job. So obviously, if you think you're doing a great job, you're wrong, because that's not the results I want for my patients. Then you look at some of the series, and even this is a recent one from Aman Patel from MGH, and the same thing, microsurgical definitive therapy, patients do better, okay? We looked at it when I was at Duke, when I was just up there now, we looked at our comparison, is my series at that time, patients do better, okay? So the big question philosophically is, why are the results so poor? We see many papers coming out that surgery results in better results. And I think it's two things. Number one, if the duration of the fistula is long-standing, then the venous congestion results in venous infarcts of the cord, which does not get better. We understand it. And, there's a spectrum. Ulnar-Forget syndrome is the real bad side of the spectrum. But you can imagine if you have a chronic venous insufficiency or venous hypertension in the brain or particularly the spinal cord, even if it's not completely infarct in the cord, it's going to result in chronic stasis. So, for example, if you have someone with venous occlusion in the brain, long term, what happens is the brain actually atrophies. So you can find, I see in cranial people with, venous occlusion. If you image those patients 5 to 6 years later, even with no stroke, you find the brain atrophy. So clearly, the long-standing venous hypertension results in problems, and it's not good for the patient. And then the other thing I always say, is the treatment making some patients worse? We already know that venous congestion is bad. Leads to the one spectrum where people will infarct the cord, but we also know from brain pathology of spinal cord, if you have venous hypertension, we are still not going to make the patient better. And the question is that we need to make sure that not only we do cure the fistula, but we mustn't create a secondary problem. And that's the important concept. And I think that many people are getting embolized now today, and we are creating a secondary problem. And why I'm saying that, I said, but now there's reasons. Number one, excessive venous occlusion from the materials going above the fistula and creating a venous stasis problem in those cases that the glue onyx goes too far. I've shown you 2 cases, and I can guarantee now, if you look at anyone's data, if you look at 100 patients that have embolizations, you're going to find, I'd say, more than half of those patients are going to have glue or onyx that's going further than the fistula, further than that actual just initial vein that you need to see. And many of those patients are going to be fine. As we know yourself, you can take something, Rod, you've done cranial cases before. You take the Sylvian vein or the vein of Labbé. Some people do fine, okay? But some people don't. So obviously, you can get away with that in many cases and going that high distance. But I can promise you now, not every patient is going to tolerate it. For me, even when I clip an aneurysm, if I find transversine veins in the Sylvian fissure, I try and minimize them because I know that in some patients I'm going to be fine, but some patients I'm going to have a massive venous infarct, and that's not acceptable for me. So I think that's the big concept of this talk, is that, you know, when you embolize things, you cannot control. You can have the most experienced endovascular neurosurgeon. You're just injecting glue. Okay, there's a certain pressure, but it depends on that pressure of that fistula where it's gonna go. So when you look at this case, I mean, this is a well-treated fistula. There's no doubt that fistula is gone. But what happens if this patient is like some of those intracranial pathology patients that cannot tolerate, that actually relies on this vein to be part of the normal venous system? There's no ways that you can say 100% of the time that patient doesn't need that vein. That is an abnormal vein, but it was placed there by God for that reason of draining venous blood. So you've taken away that vein, and I think that some patients will tolerate it, or some patients will not. So in conclusion, I hope this is not too short, but you cannot control the distance of how far the embolic material will go with embolization. Not the best guy in the world can do it, because it's a blind procedure. So therefore, in my situation, we are control freaks as neurosurgeons and spine orthopedic surgeons, and we are. That's why we go into this field. We want to have controlled environments. I think that a good surgeon, I tell my resident, a good surgeon is someone that's very thoughtful, understands the disease process, but also controls your situation. You go, I'm sure Jens and Juan, you're like me. I want the same nurse in the OR. I want the same tubes in the OR. I want the same suckers in the OR. If I go in the OR and someone gives me a sucker that's not what I use, I get upset. I don't even have music in the OR. I want to have a controlled environment, okay? And there's no ways that I can control the fistula better than surgery. I think as your fellow showed earlier, it's a simple operation. You can ligate it. Wherefore, with onyx and embolic materials, it goes higher. So for me, as a control freak, if I have a fistula, I'm going to get someone to operate on the situation. So there's absolutely no control. So I say, for me, I think the first line of therapy for young patients, unless they have comorbidities, based on the understanding of the disease process, but more importantly, understanding what embolization is and how you cannot control it, should be the first line therapy. And I can promise you, I see patients all the time that have either been inadequately embolized, the angio looks good, MRI never gets better, and you operate, the fistula is still alive, okay? And the second situation is that you've embolized it and you've created a secondary problem that most people can tolerate, but most people won't. And I think that unless you can look yourself in the mirror every morning and say, I've given this patient the absolute best therapy that I've controlled to extreme degree, I think embolization should be reserved for those people that are not ideal candidates. Okay, that's done, Jens.
That was outstanding. I can't give you a rousing sound of applause through our group, but please accept our congratulations for this outstanding talk, and thanks. So we have the good fortune of having outstanding vascular neurosurgeons here in our Swedish Neuroscience Institute, and the chief is with us, Dr. Steve Monteith. Steve, can you hear us?
Yep, I can hear you. Can you guys hear me?
Yeah. So fire away with some questions.
Gavin, that was a great talk, and really enjoyed it. And it's nice to hear that people are still doing surgery. Maybe it's because I was trained by Ed Oldfield, but we still treat type 1 fistulas as a surgical disease for the most part. I had a couple of questions, couple of a technical nature. You did the Dyna CT scan. When it's a low thoracic fistula, can you still do that on a biplane machine? Or
you try. You know, the thing about the world's not perfect, life's not perfect. Now, it depends on the size of the patient. You've got big shoulders, it's going to be hard, and that's how. But I always try, and the reason being, you know, Jens, you remember Dr. Gwen. Remember, it's got to be dural, it's got to be dorsal, okay? And all these things are important to me, okay? So the thing about it with the Dyna CT does, it gives it far better information where that lesion is. And I think that the other case that they showed in the intraoperative, it really looked like a dural fistula, but I look at the angio, if I really combine it, it may be something else, okay? They've got away with it because they treated the venous problem, but I think a Dyna CT truly gives you the understanding of where this lesion is it ventral, dorsal, is there associated venous pouches? So I think, you know, Steve, I think it's extremely important, and it takes us 10 minutes, so, and we get paid for it. So, you know, you get paid to get better data. Why wouldn't you want to do it?
Thank you. And I had two other questions. What's your approach to dealing with type 1 fistulas that come off the artery, that are fed with the artery of Denkiewicz involved in that radicular artery?
Oh, so think about it, that's another good point. For me, it's like, it's universal. I'm going to operate. Okay. Unfortunately, Steve, I hope too many people are not on this talk. They can broadcast all over the world, but I find a lot of people do things that are completely crazy. Okay. If you have one, I think Jens quoted me, and Jens heard this before, if you have a hammer, that's all you're going to use, a nail. I mean, that's what you're going to use. And unfortunately, that I see it all the time. People will try and get away with it because they,